Welcome back. This is Dr. Terkawi. In this lecture, I'm going to talk about opioid. I'll give you an overview of opioid in perioperative pain management. This lecture, as you know, is part of a series of lectures that I recommend you watch in this order. So last lecture, we learned about mechanism, background, pain assessment. Today, in this lecture, we'll talk about opioids. Let's get started. Sometimes we hear opioids, and sometimes we hear opioids. So, opiates, the substance with active integrant naturally derived from opium. So, this is naturally derived from opium, like morphine, codeine. Opioids, on the other hand, synthetically manufactured substance that mimic the effect of opium, like fentanyl, serphentalil, and etc. Opioids are the mainstay of treatment of acute post-operative pain, and morphine is the gold standard. Opioid receptors are members of G protein-coupled guanosine triphosphate regulatory proteins receptor family with signals via a second messenger such as cyclic adenosine monophosphate or an ion channel. In the ascending pain pathway, opioid receptors are located in three areas that include periphery, following inflammation, spinal cord, dorsal horn, and supraspinally in the brainstem, thalamus, and cortex. Mu opioid receptors are also found in the periaqueductal gray, the nucleus raphe magnus, and the rostral ventral medulla, which constitute the descending inhibitory pain pathway. So basically, opioid receptor everywhere in the pain pathway, both the ascending and descending inhibitory system. Also, it is available in almost every form you can think about: IV, IM, subQ, transcutaneous. We'll look over that. Now, opioids are a class of medication that work through agonism, some of them antagonism of various receptors, including mu, kappa, delta, and sigma. As you see, you have different opioid receptors here, and activating each one of them believed to cause some changes. Now, you will see if you go over different books or references, there is really no consensus about this. You will see things different sometimes. But, for example, mu1 usually the main receptor for analgesia. Mu2 for constipation. Delta mostly for behavioral changes and dependence. Kappa for sedation. And sigma for dysphoria. Now, based on their affinity, receptor binding strength, and intrinsic activity, efficacy producing the typical effect after binding to the receptor, opioids can be divided into several groups. Agonists, which display high affinity as well as high intrinsic activity, induce the typical effect of opioid. Examples: morphine, methadone, fentanyl, others. Antagonists display strong affinity but zero intrinsic activity, used as an antidote, for example, Naloxone. Kappa opioid agonists, antagonist at mu receptor. So some opioids, they are agonist antagonists, like the Nalbuphine. Partial mu agonist display high bind affinity but low intrinsic activity like the buprenorphine. And other classification, like the traditional classification here, based on the potency of the opioid, strong, intermediate, and weak. Structural classification, more pharmacological classification, and the functional classification that we just mentioned. Okay, here are four motivating questions for you. What is the oral morphine equivalent dose of 120 milligram oral codeine? What's the IV morphine equivalent dose of 120 milligram oral codeine? What's the IV morphine equivalent dose of 100 milligram oral Tramadol? What's the IV morphine equivalent dose of 100 milligram IV methadone? Now, you are welcome to pause this and think about it, and we'll go over the answers and see if we get the same answer. However, the point from this that, again, morphine is the gold standard. So everything to understand the potency of your medication and how much opioid you are giving, you have to convert it back to morphine, specifically here oral morphine. Now, to do this, here is a great slide for you. I would recommend you save this slide once I finish explaining it. Use it as your cheat sheet. So I use multiple references because also if you go over multiple references, they are not necessarily agreeing all the time. But I try my best to get you the best available references. So for example, codeine, usually they came as 20 or 30 milligram. There is no IV form of codeine. So the oral codeine to oral morphine equivalent is 12.15. And then morphine, 30 milligram orally, almost 10 milligram IV, which means you have to multiply by 3. So the IV is 3 times more potent than the oral morphine. Parenteral morphine to oral morphine is 1:3. Fentanyl is not available as oral, but it is as an IV. So 100 mic usually is, we'll see, it's 10 times more than morphine. IV and 300 times more than the oral morphine. It's very potent, 300 times more than the oral morphine. Hydrocodone, like Vicodin and Norco, again, not available as an IV, but which the conversion is 1:1, the equivalent to morphine. Hydromorphone, 7.5, 1.5 IV, so it's 5 times. And to convert it to morphine, it's 4 times. Oxycodone, 20, not available as IV, it's 1:1.5. Mayberridine or methadone, the IV is 4 times more potent than the oral, and to convert it to morphine, it is about 10 times less potent than morphine, or some references say 8 times, but let's go with 10 times. Tramadol, again, the IV is 10 times more than the oral, and it is 10 times less potent than morphine. Oxymorphone, 10 times, and it's 3 times more than the oral morphine. Now here, I want you to focus on this, the fentanyl patch or transdermal. Notice that the conversion factor is 2.4 for each mic per hour. So to help you memorize that, this is per hour. So we have 24 hours per day. That's 2.4. Just try to memorize that. So easy example here, if you have 12.5 mic per hour fentanyl patch, that's equivalent to 30 milligram morphine equivalent. Now, here, look at the methadone. The methadone, it's interesting and it's tricky. So the conversion change as the dose increase. As the dose increase, the conversion gets different. So if your patient takes from 1 to 20 milligram per day, then it's 4. Between 20 and 40, it's 8. Between 40 and 60 is 10. And more than 60 is 12. Now, to help you memorize this, I made you this small cheat sheet. So from oral, PO to PO, morphine equivalent, all multiply. So think about HM is hydromorphone. That's 4 times more than the morphine. So multiply by 4. Oxymorphone, 3 times, multiply by 3. Oxycodone, 1.5, multiply by 1.5. Then hydrocodone is 1, equal to morphine. Then after that, the green is less potent. So codeine is 0.15, mayberridine is 0.1, and tramadol is 0.1. Now, if you want to convert the same opioid from IV to PO, always multiply, because it should be higher when it's oral because of the bioavailability. So oxymorphone is 10, tramadol 10, hydromorphone 5, mayberridine 4, morphine 3. And if you want to convert from PO to IV, the number should be lower. So use the same equation, but it's a division, divide instead of multiply. The last thing, now that's the whole slide. You are welcome to save the slide, use it. When switching to different opioids, the initial daily dose for a new opioid should be further reduced by 24% if we're talking about chronic pain here. In post-operative setting, I would usually go with 50%. So we'll go over the examples here in a minute, but if you are doing any calculation and it's acute post-operative pain, still drop it down by 50. Now, what that means, this is the potency of opioid. This is a very important slide also. So that's your 0 line, the morphine. We're comparing to morphine. Anything below that, the green, it's weaker opioid. As you see, the hydrocodone is equivalent. Then tapentadol is 0.4, codeine 0.3, mayberridine 0.1, tramadol 0.1. When you go above that line, they are stronger opioids. So stronger opioid. Oxycodone is stronger. Oxymorphone stronger. Hydromorphone, morphine, buprenorphine, whether sublingual or transdermal, and fentanyl. What I would add here also is the serphentalil, which is 1,000 times as an IV. I couldn't find the conversion factor for the sublingual, which is newly approved by the FDA. We'll go over that in a few minutes. Okay, let's go back to our questions here. So let's solve this question together. So what is the oral morphine equivalent dose of 120 milligram oral codeine? Now, notice this is easy. So you have oral to oral. All what you need to do is take that 120 milligram of codeine and multiply it by the conversion factor, which is 0.15, and this will be equal 18. Okay. Now, what is the IV morphine equivalent dose of 100 milligram oral codeine? Now, notice we have IV here, we have oral here. The good news, we already have the oral equivalent of morphine from the question before, so that's 18. So I need to convert this 18 oral morphine to IV. So I need to multiply. And the number is 3, the factor is 3. So this will equal, I'm sorry, we are changing from oral to IV. So apologize, this needs to be division. So divide by 3, and that's equal 6. Okay. Now, what is the IV morphine equivalent dose of oral tramadol? So again, we have IV, we have oral here. The first thing we need to do, we need to convert the oral tramadol to oral morphine. So we'll take the 100 milligram of tramadol, and to convert it to oral morphine, we're going to multiply that by 0.1, and this is 10. Then we need to convert that 10 oral morphine to IV morphine. Again, we're going to divide by 3, and this will be 3.3. Okay? What is the IV morphine equivalent of 100 milligram IV pethidine? Okay, so the first step, IV to PO. IV pethidine to PO. So that's 100. To convert it to PO, multiply by 4. That's 400 milligram of oral pethidine or mayberridine. Then we convert it to oral morphine, multiply the 400 by 0.1, so that's 40 milligram of oral morphine. Now we'll take that 40 and convert it to IV. What we're going to do, take 40 divided by 3, and that's equal to 13.3, right? Okay, here's a more advanced example for you. A patient with chronic pain condition, taking 30 chronic pain condition, it's a back pain or whatever, taking 30 milligram of oral methadone twice daily for a long time. Admitted for pneumonia, and because of drug interaction, he developed significant QTc prolongation. He was asked to help with converting his oral methadone to oral oxycodone. Just a theoretical example. What would you recommend? Now, the first step, let's convert the oral methadone to oral morphine. Based on the previous table, with this dose, we need to multiply by 10, right? Remember that table? So this is equal to 600 milligram morphine equivalent per day. Second, let's convert the oral morphine to oral oxycodone. This will be 600 divided by 1.5, that's 400. Third, to adjust for the lack of complete mu receptor cross tolerance, we'll cut down 50%. Thus, we'll need 400 milligram per day. So far, so good. Fourth, divide the dose based on the clinical effect. So we're talking about here oxycodone. So on average, the half-life is 4. So then we'll divide it to 6 doses per day. Thus, it's 30 milligram every 4 hours. Wow, right? However, this looks like a high single dose, especially with patients with respiratory compromise. I think we will all agree on that. We can give half the dose as longer acting oxycodone, like OxyContin, 30 milligram every 8 hours, plus oxycodone 10 to 15 milligram every 4 hours PRN. This will still put him under 200 milligram, but you always can increase the dose as needed. This is an option. However, I do not prefer this option. That option, I just put it to show you how you do the math. But remember, here we are in acute setting, postoperative setting. Patient has disease, immobilized, risk of respiratory compromise. So the other option, which I think is a smarter option, however, since the patient is mostly resting, not expecting him to need that much of opioid, there's a better approach here to use a PCA plus oxycodone and avoid long-acting OxyContin. So you will cover the baseline pain and prevent withdrawal with the PCA. And once you use that for a couple of days or so, then you will see how much you can convert it back to oral. Here's another example for you. You are planning to start your patient into oral hydromorphone on postoperative day 5 after a major abdominal surgery, as the patient was strictly in PO before. The patient consumed 600 mic of her PCA, fentanyl PCA, plus she got 3 milligram of multiple hydromorphone pushes. What would be your recommended oral regimen? Okay, let's do the math here. First, let us convert the fentanyl into oral morphine, or IV, then oral. So 600 mic multiplied by 100, that's 6,000, which is 600 milligram IV morphine, which equivalent to 1,800, right? You convert from IV to oral now, oral morphine equivalent. Second, let us convert the IV hydromorphone. Remember, she got that 3 milligram into oral hydromorphone. This is easy. Multiply by 5, so it's 15 milligram. Sorry, 15 milligram. To convert this to oral morphine, you will multiply by 4. So this is 400 milligram morphine equivalent orally, right? Third, to adjust for the lack of complete mu receptor cross tolerance, we'll cut down the dose by 50%. Thus, we need 1,800 plus 600 divided by 2 is 1,200 morphine equivalent orally per day, right? Huge. Fourth, convert this to oral hydromorphone, for example, by dividing into 4. Thus, you will need 300 milligram of oral hydromorphone per day. Fifth, divide the dose based on the clinical effect. For example, every 4 hours, 6 doses. So that's 50 milligram every 4 hours. Now, again, that's in theory. But are we going to do that? Of course not. This looks like high single dose, especially with postoperative setting, and most likely the patient will require less as she continues to heal. We can schedule half the dose as 8 milligram every 6 hours and give her 4 to 6 milligram every 4-hour PRN. We can always give more. But again, I'm still not happy with this. So what we're going to do, again, better approach here to continue weaning down this patient on PCA. Why not? PCA is a great tool to wean down opioids. You can switch her to hydromorphone, PCA, and continue reducing the dose and the length of lockout, and gradually wean down, right? While introducing some oral opioids. That's how I'm going to do it. Okay. Now, let's completely shift gears and leave this math and talk about some pharmacokinetics, some pharmacodynamics, of opioids. So what are the effects of opioids in various body organs? As you see, it starts from muscle rigidity, bradycardia, vasodilation, meiosis, sedation, nausea, different mechanism on each different organ. Now, side effect of opioid. There are a lot of side effects. Most important is respiratory. So it decreases respiratory rate. The patient response to carbon dioxide is decreased, while the apneic threshold is increased. This causes respiratory depression, preceded by sedation. And this can cause or lead to aspiration pneumonia. If given large enough doses, can cause chest wall rigidity. We see that sometimes with induction. During sleep, patients who are on chronic opioid therapy develop a variety of sleep-related breathing disorder, which manifest as irregular breathing, secondary to both OSA and central sleep apnea, that will lead to hypoxia and hypercapnia. Cardiac, it can cause hypotension, bradycardia, secondary to stimulation of the vagus nerve, for example, except the mayberridine, which causes tachycardia. GI, nausea, vomiting through stimulating the chemoreceptor trigger zone and constipation. Neurology, delirium, hallucination, myoclonus dizziness. GI, urinary retention. Endocrine, inhibit release of catecholamine, antidiuretic hormone, cortisol. And during pregnancy, it does cross the placenta and goes to the fetus and cause, depression of respiration. Now, respiratory depression must be identified and treated quickly. Verbal physical stimulation of the patient, administer oxygen, respiratory support. If no improvement, administer naloxone in bolus to be repeated every minute until respiratory rate normalizes and excessive drowsiness resolves. Speaking of naloxone, it's a non-selective and competitive opioid receptor antagonist. It's a potent antagonist at the mu receptor and moderate antagonist at delta and kappa opioid receptors. The dose usually 1 to 3 mic per kilogram or 5 mic per kilogram in adults and children, and you should repeat them as I mentioned in the previous slide, and watch for side effects of withdrawal like restlessness, agitation, tachycardia, hypertension, arrhythmias, pulmonary edema, sometimes nausea and vomiting. Remember, the half-life is anywhere between 60 and 90. So if you have a longer acting opioid, then you might run out of the effect of naloxone, and you need to think about that. Infusion, it can be 1 to 2 mic per kilogram per hour for opioid-induced pruritus. Multiple routes of admission available, including nasal spray and single-use filled syringe kit. Now, nalbuphine, speaking of the antagonist, nalbuphine or Nubuffing is an agonist-antagonist opioid and binds to mu, kappa, and delta receptors. Nalbuphine acts as antagonist at the mu receptor and agonist at the kappa receptor. Like other agonist-antagonist components, interfere with analgesia produced by pure mu agonists. Nalbuphine is only available for parenteral use, and the onset of is fast, about 5 to 10 minutes, duration about 3 to 6 hours, and elimination half-life is 5 hours. Recommended as first-line treatment for opioid-induced pruritus, 2 to 4 milligram IV. Nalbuphine administration at a dose of 0.1 milligram per kilogram has been found to improve urine output in a cohort of children with opioid-associated urinary retention. So it's a potential use there. Adding nalbuphine to local anesthetic for spinal anesthesia can prolong 2-segment sensory regression time and the duration of analgesia without significant increase the incidence of adverse reaction in comparison to normal saline group, control group. Some studies even suggest they may have anti-shivering effect as well. Okay, patient at risk for opioid-induced sedation and respiratory depression. Those are with sleep apnea, morbidly obese, snoring, advanced age, opioid naive, following surgery of upper abdomen thoracic, patient with history of opioids, increased duration of anesthesia, additive synergistic effect like benzo, cardiac pulmonary comorbidities, thoracotomy, and smokers. Clinical manifestation of opioid withdrawal. Very important to familiarize yourself with this list. So flu-like illness, dysphoria, insomnia, pupillary dilation, muscle ache, lacrimation, rhinorrhea, nausea, vomiting, fever, sweating, and diarrhea. When administering opioids, the practitioner should consider the desired onset of pain relief, duration of treatment, and any potential side effect. Lipid solubility is what affects the onset of efficacy. Metabolism of each agent may also be important. It's important, especially in patients with comorbidities such as obstructive sleep apnea, where analgesia titration is essential perioperatively to avoid hypoxia respiratory depression. Opioids are eliminated by a combination of biotransformation and excretion. Most opioids are metabolized in the liver and excreted in the kidney. Thus, kidney disease must not be overlooked when administering opioids, especially morphine and mayberridine. Here is a nice table comparing between lipophilic opioid and hydrophilic opioid. So, lipophilic love lipid, okay? These are usually rapid because they pass through the cell membrane more quickly and thus bind to receptors, while on the other hand, the hydrophilic slower. Duration is shorter for the lipophilic, secondary to increased absorption, and longer for the hydrophilic. Epidural absorption and spread, better absorbed at site of injection and decreased spread to other spinal level. The opposite on the hydrophilic. Systemic absorption, rapid absorption in the lipophilic, which means increased systemic side effect, while hydrophilic opioid, slower absorption, but you get the delayed respiratory depression. Example here, fentanyl, of course, and example here, morphine. A single shot of epidural morphine, 1 to 4 milligram, or intrathecal 0.1 to 0.4 milligram, can provide up to 24-hour analgesia because of the slow absorption. Now, P450 inducers and inhibitors. This is also important to consider and look for when you are using opioid, not only in the postoperative period, opioid in general. So opioid metabolism is affected by drugs that interfere with metabolizing cytochrome P450 enzyme, most importantly, the CYP3A4. So inhibitors will increase the clinical effect of the opioids, while inducers of the enzyme will increase the metabolism of opioids that will decrease the clinical effect. So, for example, if your patient taking erythromycin or clarithromycin, you should be thoughtful about that because you will have more clinical effect of the opioid and you may end up having side effects from the opioid. So cut down the opioid dose if your patient taking one of these P450 inhibitors. The opposite is true for the inducers. Now, important concept when we talk about opioid infusion is the context-sensitive half-life. The context-sensitive half-life is the time it takes to reach 50% plasma concentration when an infusion is shut down. When running an opioid infusion, you must consider the context-sensitive half-life of various agents. This is a very popular graph. So, as you see here, the remifentanil compared to the fentanyl, the context-sensitive half-life of fentanyl increased exponentially with time, therefore making it a worse candidate for infusion or subsequent frequent boluses dosing. In contrast, remifentanil is so quickly metabolized due to the ester hydrolysis that it has become a commonly used opioid during TIVA. Then let's talk about opioid-induced hyperalgesia, which is because of substances that are supposed to inhibit pain perception, decrease the threshold of pain or pain tolerance, presumably by central sensitization. Although opioid-induced hyperalgesia is mainly associated with treatment of chronic pain, more recently it has been shown that it develops with treatment of acute pain as well. The theory that at the dorsal horn level, an ongoing stimulation from the periphery result in an increased number and altered response of the receptor involved in pain pathways such as in NMDA. The result is hyperalgesia, a decreased pain threshold, or allodynia, pain triggered by stimuli which do not normally provoke pain, even in the area which is not directly injured. A classic example here, remifentanil, but it has been also reported with others. And of course, in the chronic opioid field, we see that, a chronic pain patient. To prevent and ameliorate this phenomena, several strategies suggest or aim to reduce opioid uses here. Use multiple modal analgesia technique, use opioid analgesic with a unique profile like methadone, buprenorphine, NMDA receptor antagonist, and add small amount of antidote to opioid, still in theory. Now, let's talk about each individual opioid we use in the perioperative setting. Start with morphine. Morphine is a strong opioid which remains the gold standard agent, which all drugs that have strong analgesic effect are compared to, as we've seen in the previous slides. Various routes of administration available. Although the plasma half-life of the drug is approximately 2 hours, its analgesic duration of action is closer to 4 to 5 hours. That's because of morphine undergo hepatic glucuronidation to morphine 6 glucuronide and morphine 3 glucuronide, both of which are cleared by the kidney. Morphine 6 glucuronide is an active metabolite of morphine and is thought to be responsible for most of the analgesic effect. It contributes to side effects as such drowsiness, nausea, vomiting, coma, and respiratory depression, while morphine 3 glucuronide, on the other hand, is thought to cause agitation, myoclonus, delirium, the side effect basically. In renal failure, dosing adjustment is therefore necessary, and monitoring of side effect is important. Morphine knows to cause histamine release, and this can manifest as flushing, tachycardia, hypotension, pruritus, and bronchospasm. The onset of analgesia is rapid. The peak effect occurs about 20 minutes when administered IV. Dosing for in the acute setting, IV usually 1 to 3 milligram every 5 minutes or 10 minutes. IM 5 to 10 milligram every 3 to 4 hours as needed, and but it's painful, so it's no longer recommended. And subcutaneous, also not recommended. Neuroaxial administration of morphine, usually it follows a biphasic respiratory depression. It gives you biphasic respiratory depression early because of systematic absorption into intravascular compartment, usually in the first 1 hour, and then late, slow migration through the cerebrospinal fluid because it's hydrophilic, as we saw, and into the respiratory drive central brainstem. So the second peak usually 6 to 18 hours after administration. Hydromorphone, or Dilaudid, is a semi-synthetic opioid agonist that has a slightly more rapid onset of analgesia compared to morphine, with a peak effect about 10 minutes when given IV. Shorter half-life, about 2.4 hours. And oral bioavailability of the drug is reported to be 20 to 50% more bioavailability if given sub-Q, making it an ideal drug for long-term subcutaneous administration in opioid tolerance patients. Biotransformed in the liver, again, by phase 2 glucuronation. The active metabolites are dihydromorphone and dihydroisomorphone, and the inactive metabolite is the hydromorphone 3 glucuronate, which accumulate and can cause neuroexcitatory effects like agitation, confusion, hallucination, myoclonus, ataxia, and seizure. The incidence of pruritus following neuroaxial administration of hydromorphone is reported to be approximately 5% versus 11 to 77% reported with morphine. Dosing in the acute setting, IV 0.2 to 0.5 milligram every 5 to 10 minutes. IM not recommended, again, because of the variability in the absorption. Subcutaneous can be given orally, usually the dose 2 to 4 milligram every 4 to 6 hours. Now, codeine is an opioid agonist that has both analgesic and antitussive effect. Available as oral, subcutaneous, and intramuscular, but not IV. Codeine is a broad drug that is devoid of analgesic activity and require metabolic conversion by the CYP2D6 enzyme into morphine, which has a 200-fold greater affinity for the mu opioid receptor than the parent codeine. After administration, codeine is partially metabolized to morphine. About 10 to 15% of patients do not metabolize codeine in this way due to different genetic makeup and are therefore resistant to its analgesic effect. On the other hand, there is a group of ultra-rapid metabolizer with an increased risk of overdose. A fatal respiratory depression has been reported in newborn whose mother took analgesics containing codeine during lactation and belong to this rare group. Similar complication has been observed in pediatric patients after ENT. Thus, it has to be avoided in these two populations. Several international authorities contraindicate the use of codeine in all children under the age of 12 and children under the age of 18 after adenotonsillectomy. Codeine usually given as 15 to 60 milligram orally every 4 to 6 hours. Usually it's mixed with acetaminophen in form of Tylenol 3, which come as 300 milligram acetaminophen with 30 milligram codeine. Sometimes some manufacturers mix it with 60. And as I mentioned, we have to be careful with codeine, especially because we have potentially two unique populations. The ultra-rapid metabolizer, which put these people at a high risk of toxicity, and the poor metabolizer, which basically they don't get benefit from this. So you should avoid giving codeine on these two populations. We'll see the same thing in a minute for Tramadol. Oxycodone or OxyContin as an extended release, or Percocet as an immediate release, is the most common oral opioid used in the U.S. for the treatment of severe postoperative pain in adults. This is due to its favorable pharmacodynamics, high bioavailability after oral administration, which allow an easy transition from parenteral to oral form, and the fact that oxycodone can also be administered to adolescents as well as elderly. Can be given again IV, IM, nasal, subcutaneous. Oxycodone is metabolized by the liver, and both its metabolite and about 10% of the unchanged oxycodone are excreted in the kidney, by the kidney. The effect can last for 4 hours. Oxycodone is administered either orally. The dose is 5 to 10 milligram every 3 to 6 hours, and it can be also administered as sub-Q or IV, or even in PCA, and this is the dose here for IV. Fentanyl, synthetic opioid chemically related to phenylpiperidine. It is relatively selective mu receptor agonist, which is considered to be about 100 times the potency of morphine following IV administration. It is extensively metabolized in the liver to norfentanyl and other inactive metabolites, which are excreted in the urine and bile. So fentanyl is therefore suitable for patient and renal failure. The drug is available for IV, subcutaneous, transdermal, transmucosal, etc., neuroaxial. There's also more lipid soluble, so it's a lipophilic, as we saw, than morphine. This results in more rapid onset of action, 2 minutes when given IV, due to improved penetration of blood-brain barrier, and shorter time to peak effect, 4 minutes. Time to peak effect of IV fentanyl about 4 minutes again, and elimination about 2 to 4 hours. Fentanyl does not release histamine and may therefore be preferred in the presence of hemodynamic instability or bronchospasm. Dosing for acute postoperative pain in the recovery room is as follows: 25 to 50 mic every 5 to 10 minutes. Fentanyl patches, not that you get to prescribe it in the postoperative period, but many times you're going to encounter a patient with a fentanyl patch. Occasionally, in certain situations, you might want to start that, but the general rule is no. So it's a semi-permeable membrane with a medication reservoir. Usually the dose is anywhere between 25 to 100 mic per hour. The peak effect, 12 to 24 hour, offset prolonged by deposition in skin and subcutaneous tissue. The uptake is variable. Body temperature, body fat composition, and patch location affect the uptake. Increasingly common substance of abuse, especially among anesthesia providers. That's the IV form, of course. Sufentanil, approximately 1,000 times more potent than morphine, and it's primarily used in the operating room, either intravenously or neuroaxially, like fentanyl. So fentanyl is very lipophilic, and pharmacokinetic and pharmacodynamic profile similar to fentanyl. And there is a high intrinsic potency of sufentanil, make it excellent choice for epidural analgesia in the opioid-dependent patient. Now, sufentanil is 10 times more potent than fentanyl, right? Rapid onset of action, about 2 to 3 minutes, very similar to the fentanyl. Half-life about 90 minutes. And sufentanil appears to be less hemodynamically stability, so it's a good medication if you are doing a crani or cardiac cases. Has a very good hemodynamic instability profile. It's available as IV, IM, neuroaxial, and more recently get FDA approved as a sublingual tablet. Remifentanil is an ultra short-acting synthetic opioid. The potency of the drug is approximately equal to the fentanyl. However, remifentanil is rapidly degraded by tissue and plasma esterase, which account for its incredibly short terminal elimination half-life of 10 to 20 minutes. Rapid clearance and lack of accumulation make this very desirable opioid in the operating setting, particularly during neurosurgery as part of TIVA. Advantage, as we mentioned, is the opioid-induced hyperalgesia. It's an ultra short acting. When we look at the context-sensitive half-life, it's almost 4 minutes. So be prepared. Once you turn it off, the patient will be awake, the patient will be pain. Therefore, it's good to start another longer acting opioid at the end of the surgery in preparation for this. Now, remifentanil is associated with development of opioid-induced hyperalgesia again. Mayberridine or pethidine. It's a synthetic mu-opioid receptor agonist with short half-life. It has anti-shivering effect via the kappa receptor here. And the drug is biotransformed by the liver to normeberidine, and which is potentially neurotoxic metabolite, which has a 12 to 16 hour half-life. Repetitive dosing of meberidine can cause accumulation of normeberidine, which may precipitate myoclonus and seizure. It is therefore recommended that the total daily intravenous dose in an otherwise healthy adult without renal or central nervous system disease should not exceed 600 milligrams per day and should not be administered more than 48 hours. The dose is 0.5 to 1 milligram per kilogram, usually 50 to 100 milligram IV or IM every 3 to 4 hours. The drug is contraindicated in patients receiving MAO inhibitor, monoamine oxidase inhibitor, selective serotonin reuptake inhibitor, SSRI, and serotonin norepinephrine reuptake inhibitor, SNRI, such as Tramadol, as this may precipitate serotonin syndrome, characterized by muscle rigidity, hyperpyrexia, and seizure. Meberidine has a slower rate of metabolism in elderly and in patients with hepatic and renal impairment. This can lead to accumulation of meberidine and its active metabolite, normeberidine, which can cause seizure. Meberidine is not used for PCA because the risk of accumulation. In addition to its opioid effect, meberidine also has a characteristic of weak local anesthetic and alpha-2 agonist. Meberidine should not be used during lactation for an extended period, as it may cause neurobehavioral changes in infants. Now let's talk about Tramadol or Ultra. Tramadol works as both mu receptor agonist and monoamine receptor inhibitor. Tramadol also inhibits reuptake of both norepinephrine and serotonin. Tramadol is a prodrug which is metabolized in the liver by the CYP450, specifically CYP2D4 system, to an active metabolite, M1, which has 200 times greater mu receptor affinity and longer half-life than the parent drug. This can be significant because there can be an attenuated analgesic effect, again, in about 10 to 15% of the population, because the same thing as we saw with the codeine, the ultra-metabolizer and the slow metabolizer. Tramadol is indicated for mild to moderate severe acute pain. The drug is available at 50 milligram tablet. Recommended dose 50 to 100 milligram every 4 hours to 6 hours, not to exceed 400 milligram in 24 hours. Patients over 1 year of age are given 1 to 1 milligram per kilogram every 46 hours. The drug is also available in extended release formula and can be combined with acetaminophen. It is available in many forms: parenteral, oral, rectal, etc. Downside, side effect, nausea, vomiting as other opioids. Tramadol should be administered with caution in patients with risk of respiratory depression and has the potential to produce serotonin syndrome, which is again mental status changes, autonomic instability, muscle rigidity, hyperpyrexia, etc. So avoid it with SSRI, TCA, MAO inhibitors because of risk of also seizure with this medication. A concurrent administration of serotonin receptor antagonism like ondansetron reduce the effect of tramadol. It does also decrease threshold, so avoid concomitant administration of mayberridine with tramadol because they both decrease the seizure threshold. FDA issued warning that tramadol should not be used to treat pain in all children younger than 12-year-old or children younger than 18-year-old after removal of adenotonsillectomy. Now, let's briefly talk about tapentadol or Nucynta, which is the newer version of tramadol. It offers advantage over tramadol in terms of reduced variability in analgesia secondary to genetic polymorphism. Tapentadol metabolism will also not be subject to drug-drug interaction at the level of the CYP2D6 enzyme. Again, it's metabolized in the liver to inactive metabolites via phase 2 glucuronation, and the drug does not require enzymatic conversion to an active drug, so it's not a prodrug like the tramadol. It is available as 50, 7,500 tablets, can be given every 4 to 6 hours, and not to exceed 700 milligram on the first day of dosing, and 600 milligram every day thereafter. Tapentadol immediate relief 50 or 75 milligram provides postoperative analgesia similar to oxycodone 10 milligram with fewer gastrointestinal side effects. Advantage of tapentadol over tramadol, as I mentioned, the lack of CYP450 drug interaction, lower risk of seizure and serotonin syndrome, superior analgesia, fewer GI symptoms, less variation in individual drug response secondary to genetic polymorphism. Both drugs, the tapentadol and tramadol, has the potential to produce serotonin syndrome. So the same thing applies to avoid it and be thoughtful with the patient taking MAO, SSRI, SRI, and TCA. And also lower the threshold for seizure. Now, briefly, methadone is a synthetic opioid considered to be a broad-spectrum opioid because it has a full mu receptor agonist, an MDA antagonist. It inhibits the monoamine transmitter reuptake, making it potentially useful for treatment of neuropathic pain. So, three main things: the mu receptor, the NMDA receptor, the monoamine transfer. It's a highly lipophilic. The drug is well absorbed from the GI tract with bioavailability almost 80%. Methadone has an elimination half-life of 22 hours and following a single dose, right? Following single dose, it's 3 to 6 hours. Repetitive doses here accumulate, slowly release in the tissue, and therefore the elimination half-time life is longer after repetitive doses and unpredictable, and it can be up to 128 hours or 5 days. Peak analgesia 10 to 15 minutes after IV dosing. The drug is extremely metabolized in the liver by the cytochrome P450 to inactive metabolites, which are cleared with the bile and urine, unlike morphine. And this is why it doesn't require a lot of adjustment, and it can be given safer in renal insufficiency patients. Again, it follow a biphasic elimination phase, alpha phase, which is the distribution phase, 8 to 12 hour, and this is usually the period of analgesia. Beta phase, which is the clearance, 30 to 60 hour, and you should be thoughtful about withdrawal symptoms, and it's usually insufficient analgesia during this time. Unique and serious side effect is the QTC prolongation that can lead to torsade point. Those frequent EKG required for monitoring, and the treatment of torsade or QT prolongation is magnesium, and it's important to consider other medication concomitantly administered that may prolong the QTC. Now, this is a nice table that summarizes most of the opioid metabolism, elimination, route of administration. I will leave it for you. You can review them. And let's wrap up and talk about buprenorphine. So, buprenorphine, the reason why I'm specifically adding buprenorphine here, we are started to see it more and more in patients after surgery who are in buprenorphine. They came for surgery, and you need to know what to do with them. Buprenorphine is a mu receptor partial agonist. However, here is the key word: high affinity binding. It's partial kappa receptor antagonist. So agonist for the mu, antagonist for the kappa, and weak delta antagonist. Due to buprenorphine being a partially agonist, there is a ceiling effect. Well, that's why we like it. For binding of mu receptor, which causes decreased euphoric feeling and respiratory depression. Due to high affinity, here's the problem: buprenorphine can displace full, or it's a problem or not, based on the situation, can displace full agonist from mu receptor and cause withdrawal symptoms. Buprenorphine alone, if used as injection or snort, it can cause euphoria, and thus it can lead to misuse. Therefore, you will see that the addition of naloxone, which is an antagonist, prevents the opioid receptor activation, and thus patient doesn't get the pleasurable effect. So buprenorphine monotherapy can be reserved for pregnant patients, but usually nowadays you will see it mixed with naloxone to lower the risk of misuse. FDA-approved formula, transmucosal buprenorphine, naloxone like the Suboxone, the most popular, and others, injectable buprenorphine, the Sublocade, and buccal film, the Belbuca, transdermal patch, Butyl patch. Safety compared with methadone, used in combined pain, dosing flexibility, less structural treatment setting. These all are advantage, but it displaces opioid can precipitate withdrawal. Common side effect: headache, insomnia, diaphoresis, nausea, vomiting, constipation, abdominal pain, and sedation. Bioavailability varies between the buccal film, intramuscular, more, sublingual, very low, transdermal patch, also very low. Onset of action, about 15 minutes for intramuscular. It's metabolized by the liver CYP3A4 to norbuprenorphine, which is the active metabolite, which then undergoes glucuronidation. To a lesser extent, is metabolized by glucuronide to buprenorphine 3 glucuronide. Half-life in adult, the buccal film about 27 plus minus 11 hours, sublingual tablet 37 hours, transdermal patch 26 hours, excreted in feces and urine. Precaution, it can cause CNS depression, respiratory depression, hepatotoxicity, QTc prolongation, and hypotension. Now, the challenging question you will see, what are you going to do for this patient? Should you stop the buprenorphine before the surgery? Should you reduce the dose? Should you continue the dose? You will see different answers in the literature. And if you go read your book, it depends on when it was published. However, this is the most recent guidelines. It's a very good, comprehensive review by 5 multi-society, including ASA, ASRA. You see the names here. And they sat together and they reviewed all the available evidence and came up with this recommendation. So I personally would recommend you go by this recommendation. Perioperative management of patient on buprenorphine for opioid use disorder. Preoperative planning. Grade B, moderate level of certainty. Buprenorphine should not be routinely discontinued preoperatively. Discontinuing buprenorphine can increase the risk of opioid use disorder or harm. In most cases, avoid tapering buprenorphine prior to surgery. Intraoperative and postoperative planning, grade B, moderate level of certainty. You should use multimodal analgesia, including adjunctive medication, regional technique, etc. Consider administration of full mu agonist with high affinity for mu receptor. Can you think about opioid with high affinity here? Sure, fentanyl, of course, right? So fentanyl, especially now the sublingual form, and hydromorphone, which is the conversion factor is 4. So please go back to the slide earlier. Discharge planning, grade A, moderate level of certainty. If full mu receptor agonist is initiated, or if buprenorphine is increased during the perioperative period, a post-discharge plan to taper off the full mu receptor agonist or return to preoperative dose of buprenorphine is recommended. Engage in collaboration with the patient, outpatient buprenorphine prescriber. Grade B, consider starting, and this is for untreated opioid use disorder. Consider starting buprenorphine for postoperative analgesia in patients with suspected opioid use disorder. Grade C, buprenorphine treatment can still be considered in circumstances in which follow-up insurance coverage has not been fully established. Now, this is a summary infographic from the same paper. So, buprenorphine management, if you have a mild to moderate pain, home buprenorphine dose can be split into 2 times per day or 3 times per day. Notice the same dose, you're only making it more frequent, you're splitting the doses. If you expected severe pain, then home buprenorphine dose can be split into 3 times per day dosing. You may consider also increase the dose of buprenorphine to 24 or 32 milligram given in divided doses, or using buprenorphine intravenous 0.3 milligram every 6 hours PRN. or consider close monitoring if increasing or adding opioids for pain. Acute pain with other opioids, minimize non-opioid strategies, treat acute pain with high affinity addition. As I said, you have the fentanyl, you can use hydromorphone, and probably the sublingual serphentalil if it's available. You can try that. Close monitoring here. For the non-pharmacological, non-opioid, I would definitely go with regional anesthesia, epidural, everything, dexmedetomidine, steroidal, Tylenol, lidocaine, ketamine. We'll go over that in the last lecture, in the lecture number 5. And don't forget the non-pharmacological. I will also touch base on that. Post-operative disposition, PACU, decrease discharge home if satisfactory pain control. Again, coordinate with the prescriber and consider ICU admission if uncontrolled pain and respiratory concern. Okay, these are the general rules, and this is more references. And thank you for watching. I hope you find this helpful, and don't forget to subscribe.